We're recording. Okay, mechanisms of flow. So there are 4 types of flow, as you can see on figure 6.1 in your book on page 199. There are 4 types of flow that occur in the body. Laminar flow, which is called also parabolic flow. It's kind of like the Bell's curve, the parabola. That's what it means. It's going to be where in the middle is faster than the outer edges of the vessel, of the wall of the vessel. The velocity across the lumen of the vessel is going to be different, but it's going to be consistent. So if you look on figure 6.1, you'll see that the arrows all point in the same direction, but they're all going at different speeds. So that's laminar flow. It's constant velocity, constant direction. And typically you're going to find this in veins and small arteries. Veins, the reason that you'll find it more in veins is because arteries are going to have more of the impact of the systole and diastole, the pumping mechanism, where the veins kind of function in a different way that's more consistent flow. Spiral flow is the second type of flow, and it's also called helical. So kind of think of like the DNA spiral, just a spiral, period. And so that's the flow that you will see in that type of vessel. Vortex flow can also be called a whirlpool. And so this is where you have some type of stenosis or a stricture in the vessel. And so you initially start with, say, laminar flow, and then as you come into the stenosed area, everything kind of merges into one lane. And so once it comes out of that one lane, it's going to kind of come out and around like a whirlpool. Kind of like when you're stuck in traffic because it narrows down to one lane. And as soon as that lane opens up, the cars just go in every direction. And that's kind of what vortex flow is like. It's just a whirlpool that happens right outside of a stenosed area. Turbulent flow is a very sporadic, very random, erratic kind of flow. Different velocities, different directions. It's usually found in areas where there is kinks in the vessel, after a bifurcation, distal to a bifurcation, or distal to a stenosis, you can also find turbulent flow. It's actually the opposite of laminar flow, which is why laminar is at the top and turbulent is at the bottom. They're complete opposites of each other. The velocity is completely different. It's a very erratic flow, and it's very hard to compensate for. So when you look at these images right here, which are kind of like different representations of the figure 6.1 in your book, this is laminar flow. This is a parabola, which is like this little curve right here. And as you can see, it's consistent direction, and each of these arrows is a consistent velocity that never changes. They're just different based on which area of the vessel they're in. Vortex, so here's a stenosed area of the vessel, and now the vessel has opened back up, and as you can see, it goes from laminar. After the stenosis, it gets kind of whirlpooly or vortex. And then right outside of that vortex, you'll see that turbulent. So first, the flow is going to come out of the stenosed area into a whirlpool, and then as they're spinning in the whirlpool, they'll eventually start becoming turbulent. This is a different type of representation of it. As you can see, here's that whirlpool. Here's a bifurcation, and the directions of the arrows, as you can see, are pointing up. So this bifurcation, the whirlpool happened right after it. This is considered laminar flow right here. So in one vessel, you could have multiple types of flow occurring in the same region, depending on what is going on in that area. So that's the type of flow that we're dealing with. When we're trying to image blood in the body or CSF, we've got to think about the fact that blood is flowing in every type of way in the body. And when patients have different types of conditions or disease processes, their flow is going to also be different. Excuse me, sorry. Okay, so we talked about the 4 types of flow. So now we're going to talk about the flow mechanisms. Flow can be classified by the type or the mechanism. There are 3 types of mechanisms. First order, which is laminar flow. That's the most ideal type of flow, the constant velocity, constant direction. Second order motion, which is accelerating flow, and third order motion, that's jerky flow. So first order motion is laminar. Second order would be like vortex, where it comes through a stenosis and starts accelerating. And then turbulent would be third order or jerky motion. During data acquisition, the only type of flow that we can actually compensate for using our data acquisition processes is first order flow, which is that constant velocity, constant direction. And we typically make up for that with gradient moment rephasing, or we also call it gradient moment nulling. And this is a type of compensation technique that we use to allow us to compensate for the flow and correct the phases and bring everything back to in phase. And we'll talk about this in just a little bit, but I just wanted to kind of throw this in here. It is just like the balanced gradient system that we talked about in our equipment and methodology class. I think that's where we talked about it. So it's that bipolar gradient application. So the only one that we can truly compensate for during data acquisition by using those bipolar gradients is first flow order or first order flow. But most of us do not have first order flow in our entire body because we're human and things happen. So, and also because blood flow is pulsatile, so it's not going to be constant all the time. And the reason it's pulsatile is because of the pumping mechanisms of the heart. The systole and diastole cause that pulsatile flow. So pulsatile flow is more closer to second or third order motion. And since we can't compensate for those during data acquisition, we have to use specific techniques to actually allow us to image the flowing blood properly. And so that's what we'll be talking about today. So flow phenomena is the types of artifacts or the types of signal that we will actually get from blood when we are imaging it. Flowing nuclei, whether it's blood or CSF, is going to have different characteristics from stationary nuclei. So for instance, the liver tissue is stationary, but the hepatic artery has flowing nuclei in it. So when you're imaging the liver tissue is going to exhibit a different type of contrast than the flowing nuclei in the hepatic artery, for instance, right? So because they're creating different types of artifacts, we've got to kind of compensate for those artifacts by using different techniques. One way that we notice artifacts, it happens quite frequently, is this phase ghosting or mismapping. And this is actually something that we talk about more in our artifacts unit, which is coming up after this unit. But I wanted to kind of bring it up in this unit because it relates to what we're talking about today. So this is an axial view of the hip, and they're looking at, or they're pointing arrows at these little ghosting looking circles that kind of run across the width of the image. These are actually from either the femoral artery or possibly something in the pelvic region. I don't know exactly which one this is. So what's happened here, and one thing to really remember is that phase ghosting or mismapping only occurs in the phase direction. And we'll talk about this more in our artifacts unit. So don't worry about why that is, but just know for now that phase ghosting or mismapping occurs in the phase direction. So when we look at this image of the axial hip, which direction is technically the long axis of the body? Is it front to back or is it side to side? Think about the body itself. We're looking at an axial view of the hip. So which direction is going to be the long axis of the body, and which direction is going to be the short axis of the body if we're looking at an axial view of the hip? Don't look at the square itself. Go ahead, Laura. And I see Lena said side to side. What do you say, Laura?
Right to left. Right to
Yes, so
left.
Lena and Laura, you're both correct. It is left to right or right to left. It's the direction going this way. This is, if we were to add another axial view of the hip on the other side, the body itself, the long axis is across the right to left direction. But we're seeing this ghosting happening in the right to left direction, but we know that our phase direction is always in which axis, the short or the long? Any guesses? You should kind of know this already, but you can guess if you want. That's correct, Lena. It is the short axis. So what's happened here is, even though the long axis of the body is left to right, for some reason, the person who created this image did not check their phase direction and did not put it front to back. Either that, or if they put it front to back, then the phase ghosting would run directly through the joint space. And so to avoid this running through the joint space, which is what we're looking at, they made the phase direction go left to right. So yeah, we're going to get some ghosting, but it's going to happen outside of the joint space, which is why we're performing a hip axial view, to look at the joint space of the hip and the anatomy directly there. So this is actually motion. This is flow of the artery that we're looking at, or the vein. I'm not sure which one it is. Every time they take a picture, every time the RF pulse is pushed through the patient, the nuclei in the vessel have moved in a different position along the vessel. And so it kind of manifests on the image as this like train of ghosted looking circles in the shape of the vessel. So that's one of the ways that flow can interfere with the image and produce an artifact. And there's actually 3 types of flow phenomena that cause these flow artifacts: time of flight, entry slice phenomenon, and intravoxel dephasing. I will say that in this lecture, there's a lot of lists. There's a lot of different types that you're going to have to kind of keep up with. Write it down, make your own lists, make your own charts, make sure that you are not confusing one with the other. And they're there for a reason, because you will be tested on them in this class as well as on your registry. So that's why they're here. So the 3 types of flow phenomena that we encounter in the body are time of flight, entry slice phenomenon, and intravoxel dephasing. And so I feel like intravoxel dephasing is kind of self-explanatory, but I will go over it briefly, and I'll cover these 2 a little bit more detailed. So let's do a little knowledge check real quick. Who can answer the first one? What are the 4 types of flow that we encounter in the body? Go ahead, Jasmine.
Laminar flow, spiral flow, vortex flow, and turbulent flow.
Yes, perfect. Laminar, spiral, vortex, and turbulent. Good job. Reggie, do you want to do the next one?
Yes.
Okay.
Let's see. Laminar flow has consistent velocity and direction.
Perfect. All right, who wants to go for the third one? Go ahead, Lena.
Vortex flow is the same after stricture or stenosis.
Yes, ma'am. And last one. Ooh, hearing myself on that feedback. I hate the way I sound on recordings. 3 types of flow phenomena creating flow artifacts. Go ahead, Reggie.
Time of flight, entry slice phenomenon, and intravoxel dephasing.
Perfect. Time of flight, entry slice phenomenon, and intravoxel dephasing. And I use a lot of hyphens, but sometimes some of the things that I type out in hyphens are not hyphenated, but I just like hyphens. I think they're very important. Okay, so let's talk about time of flight phenomenon, which is the first flow phenomenon that we'll encounter. So in order for a nucleus or a nuclei or a spin to produce a signal, we need to be able to excite and rephase it. We've known this from day one. You got to push an excitation pulse into the body, and then you've got to rephase that pulse or those spins in order to bring them into phase and generate a really strong echo. Because if you don't use a rephasing pulse or a rephasing gradient, then you are going to only be using your FID, and FID is just not a very clean signal. So we have to rephase them in order to create this really nice, strong echo. So when we're talking about flow, we always talk about stationary versus flowing nuclei. And a really good way to remember this is some parts of your body don't move and some parts of your body do. And by move, I'm talking about like cellular level. So you have the cells in the tissue of, say, your liver, again, those are not going to go anywhere. They're going to always be present in the slice as you're imaging it. The blood that's flowing through the vessels, however, is not going to always be present in the vessel the entire time that you're imaging that slice, that you're scanning it, doing all of your pulses so that you can create your 25 slices for that particular scan. So the flowing nuclei is sometimes not going to be present for excitation and rephasing. Sometimes it's only going to be present for one or the other. And so that type of situation is what we call the time of flight. And so I don't know if you guys like to correlate things with each other. For me, I do, because it helps me remember. And so when I'm trying to remember the time of flight, I'm thinking about how long it takes the nuclei or the blood or the spins to fly through the vessel. So are they going slow? Are they going fast? Are we looking at it in a bigger view or a smaller view? So we'll kind of go over that in just a minute. So if you turn to page 201, sorry, is figure 6.2, and I'll have this also on your slide. So this is kind of where we're looking at it right now. Also, as a side note, in your chapter, if you see a learning point, even if I don't point it out, make sure you read it. Just because I don't point it out doesn't mean it's not important, but if I pointed everything out in the book, I'd be rewriting the book in the slides, and that's kind of pointless. Okay, so blood and CSF is going to be considered flowing nuclei, and like I said, sometimes it's going to be present in the slice for excitation, but not for rephasing, or it'll be in the slice for rephasing and not excitation. That is time of flight phenomenon. And the effects of time of flight are going to depend on the pulse sequence that we use, whether it's spin echo or gradient echo. So in the time of flight phenomenon, there's two different things that can happen depending on which sequence we're using. Time of flight in the spin echo is going to create a signal void. That means the vessel is going to appear dark. So anytime you use spin echo, you're going to have what's called dark blood imaging or black blood imaging. And it'll be mentioned multiple times today. But just remember that with spin echo sequences, the time of flight phenomenon creates a signal void. So you're not actually going to get a bright signal from the blood flow. It's going to be the opposite. Now, every slice is selectively excited and rephased in spin echo. That means that when we are pushing the excitation pulse into the patient, we're pushing it for that specific slice. And then when we're rephasing for that specific slice. And so as we are doing that, only that the spins in that specific slice and maybe the spins right around it are going to be the most impacted by that pulse because of our, what's the word that I'm thinking of here? Because of our slice select, phase encode, and gradient encoding. So we have selected and specified what we're going to be exciting and rephasing in spin echo, which is different than gradient echo. So in stationary nuclei, they're going to take both the excitation pulse and the rephasing pulse. So they're going to be exposed to both. And in order for us to create a signal, both of the nuclei has to be excited and rephased. So stationary nuclei are always going to show up with the nice contrast that they're going to display based on what type of contrast weighting we're doing. So T1, T2, whatever. Flowing nuclei, however, may or may not get both pulses, and typically will not get both pulses because they're moving and the pulses take time to happen. So they could be excited but not rephased, which means that they're going to leave the slice before they get the 180-degree rephasing pulse. Because they're not getting both pulses, they're not producing a signal. Or they could be outside of the slice before they get excited, and so they don't get excited because they're not in the slice, and then they enter the slice and they get rephased, but they're only being exposed to a 180-degree pulse. If a spin is only exposed to a 180-degree pulse, what is happening to that spin? Do you guys remember what happens if the first pulse that a patient or the signal, the spin receives is a 180-degree pulse? What is actually happening to that spin? Think back on our types of pulse sequences. Which pulse sequence starts with a 180? Wake up. Yes, perfect, Jasmine, an inversion pulse. So if we are only exposing a nuclei to a rephasing pulse, we're actually saturating it out because we're inverting it. So it's not going to show up with a signal because we're not giving it an excitation pulse, or it's not going to show up a signal because we're only rephasing it. So flowing nuclei in spin echo are going to always show up as a signal void for these two reasons. Either they're going to be present for the excitation and not the rephasing, or they're going to be present for the rephasing and not the excitation. So if you look at figure 6.2, and do I have it on here? I'll get to it in just a second. If you look at figure 6.2, you can see that on the top of the image, you have a 90-degree excitation pulse followed by a 180-degree refocusing pulse. The three vessels are actually the same vessel. We're just looking at it in three different positions. So the yellow box is your slice. It's the actual slice that we're trying to create an image from. Notice that in the top box, or in the top vessel, the nuclei is present for both excitation and rephasing. So then it's going to create a signal. In the middle one, the nuclei is only there for excitation but not rephasing, so it's not going to create a signal. And in the bottom one, they're not there for excitation, but they're in the slice for the rephasing, so therefore no signal. So that is what occurs with time of flight and spin echo. The effects of time of flight and spin echo are going to depend on these three main factors. And these three factors are, if you kind of think about them in a bigger picture, you'll understand them better. But we're going to break them down first. The first one is velocity of flow. How fast are the nuclei moving? Naturally, if a nucleus is moving too fast, it's not going to be in the slice for both excitation and rephasing. If it's moving slow enough, we can actually catch it both times. So if you think about somebody who has slow flow, maybe it's because they have a stricture, or maybe it's because they have some type of condition that's causing their blood to move slower. So that would possibly allow us to image that nuclei even in spin echo. Time of echo is another factor. It's how long we wait before we push the next excitation pulse. So are we going to give it a long time or a short time? And in that time frame, how much nuclei are actually passing through without us exposing them to both excitation and refocusing? And the third one is slice thickness. The bigger the slice, the more likely you're going to be exciting and rephasing the spins at the same, the same spins. The smaller the slice, the less likely that you're going to be able to do that. So we're going to talk about those a little bit. Remember, time of flight in spin echo equals a signal void or a signal loss from the vessel and the blood in the vessel, which is not a bad thing. We can use that to our advantage to view the vessels themselves. Okay, so let's look at velocity of flow. This is the same image that's in your book. So there are two types of situations that occur when it comes to velocity of flow. High velocity signal loss, pretty self-explanatory, or flow-related enhancement. Anytime you see the word enhancement, just think bright signal or a signal, just a period, a signal from the actual nuclei. High velocity signal loss is the velocity is going to contribute to whether or not we're going to have signal from the spins. Like I said, if they have an average flow velocity, they're going to be present in the slice for both excitation and rephasing. As the velocity of flow increases, less flowing nuclei are present for both excitation and rephasing. So notice here, the faster the flow, the most likely that they'll either be in for one and not the other, whether it's excitation or rephasing, but they're not going to be present in the slice for that particular nuclei. It's not going to get both of those pulses. So as the velocity of flow increases, there's an increase in the time of flight effect. Remember, the time of flight effect in spin echo is a signal void. So the faster the velocity of flow, the more signal void you're going to have, the more time of flight effect you're going to see. And vice versa. As the velocity of flow decreases, the time of flight effect decreases, which means you're going to actually have a signal. So that's called flow-related enhancement. We are enhancing the signal. As the velocity of flow decreases, there's a decrease in the time of flight effect. So therefore, we are creating a signal. This is only in spin echo. It's different in gradient echo, and we'll talk about that as well. Any questions about this so far? Okay. Time of echo is that second factor. Velocity of flow, time of echo, and slice thickness. Those are the three factors that affect time of flight phenomenon in spin echo. So time of echo is how long it takes us from the excitation to the collection of the echo. The longer that our time of echo is, the longer that we wait before we actually push the refocusing pulse. We don't want to push the refocusing pulse really early if we have a time of echo that's really long, because then by the time we collect the echo, it's already decayed. So therefore, we have to wait a little bit before we push the refocusing pulse. So as the time of echo increases, you run the risk of the nuclei leaving the slice before you rephase them. So notice here we have this 90-degree excitation pulse. Here's the slice thickness, which is the yellow box. And notice that the slice is always perpendicular to the vessel, okay? This is something that you'll read about in the book and that you'll hear. It's not something you have to think about as a technologist because it's going to be perpendicular to the vessel regardless, but they just have to make a point to throw that in there. So our slice thickness is right here. So we have the spin present in the slice for the excitation pulse. But because we're waiting so long to push our refocusing pulse, because our time of echo is longer, the nuclei has left the slice. It's still moving down the vessel, but it's left the slice before we rephase it. So therefore, there's no signal. That particular nuclei is not going to produce a signal for us. So as the time of echo increases, then our time of flight effect is going to increase, which means we're going to have a signal void. And the opposite is true. As you decrease your time of echo, you decrease the time of flight effect, so therefore you have signal enhancement. The longer your time of echo, the more likely you're going to lose signal. The shorter your time of echo, the more likely you're going to create a signal because you're able to actually excite and rephase the spins, I guess you could call them, before they leave the slice. The major point here is, where are our spins in the slice in relation to the slice? Are they in the slice when we're exciting and rephasing, or are they outside of the slice for either of those? That's kind of the point here. Okay? Slice thickness is that third factor, and it's kind of similar to time of echo. You know, the bigger the slice, the more likely that your spins are going to be in the slice for both excitation and refocusing. And the thinner the slice is, the less likely you're going to have that spin in both pulses, present in the slice for both pulses. So in thick slices, you're going to decrease the time of flight effect. You're actually going to produce a signal because they're present for both. And in thin slices, you're going to increase the time of flight effect, which means a signal void. So this is kind of a summary of what we just talked about in chart form for spin echo. With flow-related enhancement, which means you are enhancing the signal and actually creating a signal from it, you want to make sure that your velocity of flow is decreasing. You want, if you're able to, now of course you can't do anything about it, but as the velocity of flow decreases, you're going to be able to excite and rephase those spins. As you decrease your time of echo, you're going to be able to excite and rephase those spins before they leave the slice. As the slice thickness increases, you're going to be able to excite and rephase those spins in the slice. And vice versa, for high velocity signal void, kind of self-explanatory. The faster they're going, the less likely you're going to get a signal. The longer your time of echo, the less likely you're going to get a signal because they're not getting both excitation and rephasing. And the thinner your slice, the less likely you're going to get a signal. Any questions? Let me know if I start sounding like Charlie Brown's teacher so I can go back and review with you. Okay, so that was time of flight and spin echo. Now we're talking about gradient echo. In gradient echo, unlike spin echo, we're not using a refocusing pulse, we're using gradients to rephase. With a refocusing RF 180-degree pulse, which is used in spin echo sequences, it is slice selective. We have to choose a slice select gradient for every excitation and refocusing pulse. That means that we are telling the system this slice is what we are focusing on. In gradient echo, you only choose the slice select gradient in the very beginning with your excitation pulse, and you never choose it again for the remainder of that TR. That's because we're using gradients. Gradients are across the entire length of the magnet. Therefore, when we use gradients, it is affecting the entire body. So that means that in gradient echo sequences, when it comes to flow, we are always going to have a signal. They are flow sensitive. That means that we're always going to have that signal enhancement. The reason for that is because flowing nuclei are going to get that variable excitation pulse at the beginning of the sequence. And regardless of where they are in the slice, whether they're in the slice or out of the slice, they're going to get rephased. And remember, in order for any nuclei to produce a signal, they have to get excited and rephased. And since our rephasing pulse, so to speak, in gradient echo is using a gradient, the entire body is getting rephased, regardless if it was excited or not. The slice is, the spins are getting excited selectively because we're using a slice select gradient in the first part of the sequence. In the first part of the TR, we're using a slice select gradient. Let me draw for you so that you can kind of, hopefully you're already understanding me, but just to be safe. So we have our variable excitation pulse, and this is our slice select in gradient echo. And then we have our phase encoding gradient, and then we have our frequency encoding gradient where our echo is. Notice that the slice select gradient only occurs at the excitation pulse. That means that the only time that we are selectively exciting anything is at the very beginning of our pulse sequence. The next time that we select a slice select gradient is at the next excitation pulse. In spin echo sequences, we're actually going to be exciting 90 degree, slice select, 180, slice select, 90, slice select, 180, slice select. So every single time we are pushing a pulse, we are selectively choosing where that pulse is going. With gradient echo, we only do that with the initial excitation pulse. So because of that, our entire body is going to get rephased whether or not it was excited. Well, the only things that are going to produce a signal are the things that were excited first, because you need to be excited and rephased to create a signal. So even though we're rephasing the whole body, we're only going to get a signal from those spins that were excited. However, even if the signal or the spins are not in the slice, they're still going to produce a signal because they were excited and then they're going to be rephased. So another thing to think about with gradient echo is that our TR and TE are usually really short because of the fact that it's a gradient echo and it's a shorter sequence, and we don't need a longer time frame because we're using gradients, whatever. So the stationary nuclei are going to get saturated out because they're going to continue to receive those RF pulses, the excitation pulses. And so because the TR and the TE are short, we're never giving those stationary nuclei enough time to longitudinally relax. And so eventually, as we keep pushing pulses, they're going to eventually fall into the inverse plane. So stationary nuclei, like the liver tissue, is going to actually be darker than flowing nuclei like the hepatic artery, which makes gradient echo sequences fantastic for flow sensitive studies, because not only are we always guaranteed a signal from flowing nuclei, because we're rephasing with a gradient, which is not slice selective, so we're going to always be able to catch a signal from the moving nuclei, but also we're saturating out the stationary nuclei, so there's a really high contrast between the vessel and the tissue, and that means that the image is just going to look even better. So that's why typically we're using gradient echo sequences for bright blood imaging. That's what we call it, because the blood is actually appearing bright, because it actually looks so contrasted. We have a great contrast between the flowing nuclei and the stationary nuclei. All right, let's fill in some more questions. The 3 factors that affect time of flight phenomenon are what? And I didn't make these long, but you know, whatever. Go ahead, Laura.
Is it velocity of flow, time of echo, and slice thickness?
Yes. Correct. Sorry. My pillow, my back was hurting this morning, and my pillow doesn't feel right, and I'm just a hot mess. Okay, correct. Velocity of flow, slice thickness, and what did you say the third one was?
Time of echo?
Yes, correct. Okay, next blank. What occurs? Something occurs when the velocity blanks, TE blanks, and blank blank increases. This is kind of a confusing one, so just kind of think about it for a second. Oh, go ahead, Laura.
Okay, I think this is what it is. I'm not sure. Enhancement occurs when velocity decreases, TE decreases, and slice thickness increases.
Perfect. So when you're looking at this, the only thing I'm giving you is that something is increasing, and it's got 2 blanks, which is slice thickness, right? So if the slice thickness is increasing, that means that we are actually enhancing, flow enhancement. It's called flow-related enhancement. So that's what you would put on here. So that's when you have slice thickness increasing, time of echo decreasing, and velocity of flow decreasing. Does everybody understand why that is? Or does anybody need me to explain this? Okay. Next blank. Which sequences use something to rephase, which is applied to the whole body, making them another term for flow signal enhancement? What are the sequences I just talked about? Somebody besides Laura. Sorry, Laura, but I need more participation from everyone else. You're doing great. I'm going to start calling all y'all, so you better start raising your hands. I can't be the only one that's wired and awake today. Okay, Lena, let's do you. What's that last blank? Go ahead.
Gradient sequences uses gradients to rephase, which are applied to the whole body, making them I don't know that last blank.
Okay, Reggie, do you want to try that last blank?
Okay, I'm gonna try it. And those other two I didn't have. Flow sensitive.
Yes, perfect. So GRE sequences, yeah, pat yourself on the back. GRE sequences use gradients to rephase, which are applied to the whole body, making them flow sensitive. The sequences are flow sensitive, not the gradients. All right, cool. So that was the first phenomenon, time of flight. Remember, there's 3 phenomena: time of flight, entry slice, and intravoxel. Entry slice phenomenon is a little bit different, and this starts on page 203. So we call this inflow effect. Think about it like as you go through the buffet line, initially you're starving, okay? So you're just eating everything. By the time you go through the entire buffet line, you're now so full that you're really not picking up anything to eat. That's kind of similar to what entry slice phenomenon is. As the spins or the nuclei are moving through the slices that we're taking, they're going to go from a bright signal to a dark signal, or from a dark signal to a bright signal. And that's what we're going to talk about today. It's based on the excitation history of nuclei. And so if you go to page 204 on figure 6.4, excuse me, we're going to talk about those saturated spins versus fresh spins or inflowing spins. And so far, when I talk about saturated spins, I'm talking about those stationary spins, right? Stationary background spins and inflowing spins. Inflowing spins are going to come through the slice, and they're not going to get saturated because they're still fresh. They're barely coming into the slice. Stationary or background spins are sitting in the slice the whole time it's being excited and rephased. And so eventually they're going to get saturated out because they're constantly being pushed into the transverse plane without enough time to fully relax. So that's really the excitation history of nuclei, whether or not you're going to be able to fully relax, whether you're fresh into an excitation cycle, or whether you've been completely saturated out. So nuclei that receive those repeated RF pulses with short TRs are saturated out. Short TR is important because in order for us to saturate them, we can't let them fully relax. We have to continue to push them into the transverse plane so that they can eventually become saturated out in the inverse plane. That's because they have that less longitudinal recovery. Nuclei that do not receive the repeated RF pulses, so flowing nuclei, because they're not in the slice for every single pulse, are called fresh. Their magnetic moments are going to stay in the spin up. They're not going to be inverted into the inversion plane, so we don't saturate them out. And so they're going to produce a different signal than the stationary slices. And this is called entry slice phenomenon or inflow effect. The fresh spins are going to produce a higher signal than any of the other spins that are in the slice that are continuing to get saturated, or the RF and excitation and refocusing pulses. So how often the nuclei receives those repeated RF pulses is going to actually determine the magnitude of the entry slice phenomenon, and I'll call it ESP from now on. So, or inflow effect is another way to call it. In the stack of slices that we're imaging, and you can kind of see on figure 6.5, in the stack of slices, there's 1, 3, 5, and 7 slice, because they're kind of we'll talk about this interleaving, which is how you acquire your slices. You can either acquire them sequentially, 1, 2, 3, 4, 5, 6, 7, or you can acquire them interleaved, which means that you're skipping them. So we'll talk about that later. But on this image, they're collecting slice 1, 3, 5, and 7 in this TR period, for instance. So the top vessel on figure 6.5 shows the direction of the spin moving into the slice from left to right, into the slices from left to right. Where on the bottom vessel, the spin is actually going from right to left. So when you're first imaging a slice, if the spins are barely coming in to those stack of slices, so the top vessel where the spin is on the left-hand side, that spin in the first slice has never been excited or rephased, has never had any type of excitation pulse. It's fresh. We are freshly exciting it and rephasing it. So therefore, it's going to produce a really high signal because it's fresh. However, by the time it gets to the very last slice in the stack, it has been excited and rephased, excited over and over again with a short TR, that by the time it gets to the very last slice, it's not going to produce much of a signal intensity. That's what we mean by entry slice phenomenon. Where are the spins compared to the first slice in your stack of slices? Now, this has to do with, first of all, the direction of flow of those particular vessels and which order you're taking your slices. Are you running your slices top to bottom or bottom to top? And which direction are your spins running in, top to bottom or to bottom to top? So again, in the first stack of slices, in the first slice of that stack, you're usually going to have those fresh flowing nuclei. In the middle stack, they're going to show a little, and that's that entry slice phenomenon, which means in the entry slice, that blood is just producing a really bright signal. In the middle stack, they're starting to exhibit less of that entry slice phenomenon because now they've been exposed to a few more excitation pulses, and so they're starting to get a little bit more saturated. Remember, this is with a short TR, and so therefore we're kind of pushing them into the transverse plane over and over again without much longitudinal relaxation. By the time we get into the stack, they have been pushed into the transverse so many times without relaxing that we have now saturated them out. So again, the ESP magnitude is going to depend on the rate at which the spins receive their excitation pulse. How often are they going to receive their pulse is going to determine how strong our ESP effect or phenomenon is going to show up. Here's some more lists for you. So these are the things that determine the magnitude of the entry slice phenomenon. First of all, a short TR. The shorter your TR, the more likely you're going to have this entry slice phenomenon happening on the first slice. If your slice is thick, then you're not going to have as much entry slice phenomenon because the nuclei are going to receive more RF pulses in that slice, which is going to saturate them out. In thin slices, the nuclei are going to receive less RF pulses, so they're not going to get saturated out. And this can get kind of confusing when you start talking about time of flight versus entry slice, and they all kind of sort of work together, but just try to focus on each one individually. When we're talking about time of flight, we're talking about time of echo, velocity of flow, slice thickness. Notice that in entry slice, we're also talking about slice thickness and velocity flow. So they're very changing and interacting, but we're just going to focus on them individually for the purposes of understanding each of these phenomena separately. All right, so with thick slices, they're going to receive more of those pulses. They're going to saturate them out, which means they're not going to have as much of that entry slice phenomenon where the signal is bright. Velocity of flow, the faster they're moving, they're going to receive less pulses. So therefore, as you slow down the velocity of flow, or as the velocity of flow slows down, you're not going to have as much of that entry slice phenomenon. Because going back to the slide beforehand, with entry slice phenomenon, the brighter signal is going to happen to the spins that have not been exposed to multiple RF pulses. The fresh flowing nuclei, the fresh spins, are the ones that are going to produce the entry slice phenomenon, which is the bright signal. As they continue to get extra pulses in that slice, they're going to be less and less bright, or in that sequence, so to speak. And direction of flow is actually the most important factor, and that's that figure 6.5 that we were just looking at. It is going to determine the magnitude of ESP throughout the entire stack of slices. So when we're talking about an individual slice, we're really kind of focusing on these three factors, but the direction of flow is really the most important. And learning point on page 205, which goes into page 206, is actually also connected to the images that are on page 208 and 209. So turn to page 208 and 209 for me, so I can kind of go over it in just a minute. Let's look at this slide to kind of review direction of flow. Remember, in ESP, direction of flow is the most important factor. TR is important because the shorter the TR, the more likely we're going to saturate the spins out. Also velocity of flow and slice thickness. But direction of flow is the most important, and this is why. If your flow is co-current, which means that it is opposite of the direction that you're acquiring your slices, then you are not going to have co-current is in the same direction. Together. Come on, Razan, get it together. Co-current. Co-current means that the flow is moving with the slices. So these are slice 1, 2, 3, 4. These are sequential slices that they have acquired. The spin is moving through the slices as we are acquiring them. So that means that every time this spin is in a slice, it's getting excited and rephased, excited and rephased, excited and rephased. And notice that as it moves through the slices, it goes from really bright to really dark. We have saturated it out because we are acquiring the signal as it's being exposed to the RF excitation pulse, sequentially moving along with the RF excitation pulse. Countercurrent is the opposite of that. The spin is actually moving through the slices in the opposite direction that we are exciting those slices. So because of that, the spin actually remains fresh. So we're exciting slice 1, but the spin is back here, and so it's going to show up really bright. It's going to have a really bright signal. As we expose or excite slice 2, the spin is still over here, so it's still, and remember, especially in gradient echo sequences, we're going to always get a signal if they're getting excited and rephased. So as it's moving co-current or countercurrent, it's actually going to be brighter in more slices. With co-current, where the flow is in the same direction as slice acquisition, the slices are going to be less, the spins are going to be less bright. The flowing blood is not going to show up very bright after the first slice. In countercurrent, where the flow is opposite of slice acquisition, every time that nuclei enters a slice, it's actually fresh because it hasn't been excited and rephased at the same time. And so once it comes into the next slice and it gets excited and rephased, it's fresh. And then it goes into the next slice and it gets excited and rephased, it's fresh again because it's not moving along the same direction as the RF pulse and the slice acquisition. So let's look at page 208 and 209 because visually I think it helps understand it a little bit better. So starting at figure 6.6 is slice 1. Underneath it is slice 2. Next page, top of the figure 6.8 is slice 3. And then slice 4 is on figure 6.9. Now we're looking at the vena cava and the aorta. And notice that on axial T1 image slice 1, which is the most inferior slice, you have a bright signal from the vena cava, but not a bright signal from the aorta. And I hope you guys know where you're looking. If you don't know where you're looking, review your sectional anatomy. So the vena cava moves blood from the bottom to the top of the body, right? Technically, the inferior vena cava, the IVC. So the inferior vena cava is moving blood from the bottom of the body to the top of the body towards the lungs and heart. The aorta is moving blood from the top of the body to the bottom of the body. So the aorta is going to be co-current and the inferior vena cava is going to be counter-current. So if you look at this diagram on your slide, as you're looking at the images, you can see that the direction of flow on this lower vessel is like the inferior vena cava. So therefore, if the most inferior slice is this one, slice 4, which on your image in the book it says slice 1, but for our purposes, let's assume that the lowest most image is slice 4. Well, if the inferior vena cava is at the bottom, it's going to be fresh coming into the slice, right? So therefore, the inferior vena cava is bright, but your aorta is dark because it is up here and it has moved through all of these slices and has been excited and rephased before it actually got to this point. Now, once we reach the top of the body, for instance, and we're on this last most superior image, our blood that's coming from the aorta is fresh. And so the very last slice is going to have bright blood from the aorta and dark blood from the inferior vena cava. So it's about which direction the blood is flowing and which direction we're acquiring the slices. If the slices are being acquired in the same direction of blood flow, you're not going to have as much of the entry slice phenomenon if they're going in the same direction, because they're going to get saturated out. And by the time we finish acquiring our slices, all of those spins have been saturated out. If we are going opposite, pretty much every time that we're looking at blood in the sequence, it's fresh blood for each of those slices. So by the time that we take slice 2, the spins that we've excited and rephased are long gone. And now we're getting a totally fresh blood signal because it's just going against the grain. So just remember with direction of flow that it is the opposite. As you move opposite of each other, you have a higher chance of that increased entry slice phenomenon. So every time the blood enters a slice, it's fresh. If you're going with the flow, you're acquiring your slices with the flow, you're going to decrease that entry slice phenomenon. So you're not going to have as bright of a signal. So, and then notice on figure 6.7 and 6.8, the signal contrast for both the inferior vena cava and the aorta are almost exactly the same, because they're both in the middle of the stack of slices. And so the blood has been exposed to excitation pulses a few times now. And so it's kind of, you know, more of a equal signal contrast. So you're either going to have bright signal contrast in the first slice or the last slice, depending on the direction of acquisition and the direction of flow. Any questions about this so far? Okay. So to summarize entry slice phenomenon, you increase that phenomenon, or ESP, which means that you're going to have bright signal from inflowing nuclei more so in the beginning slice of the stack when you're using a long TR. And the reason that when you use a long TR, because you're allowing longitudinal relaxation. So when you allow longitudinal relaxation of spins, that means that every time you excite them again, they're fresh, so to speak. They have not been excited and pushed into the transverse plane. The shorter your TR is, the less longitudinal relaxation, which means that they're not going to be as fresh. So using a long TR, using thin slices so that they're not getting exposed to pulses within that slice repetitively. Moving fast flow, the faster the flow is, the more likely that you're going to have bright signal from the nuclei along the entire stack. And when it's counter current flow, that means the flow is going opposite of the slice acquisition direction. And you can always change your slice acquisition direction. You can get your slices from left to right, right to left. If you're doing axials, you can go top to bottom, bottom to top. If you're doing coronals, you can go front to back, back to front. It's all about what you want to do. And as a technologist, the more you understand how those options work, the more you can manipulate your images the way you want them to be manipulated. So typically, whenever you're doing, for instance, carotid arteries. So the carotid arteries are moving from the aorta in the middle of your chest. The blood is moving up, right? So we want to get bright signal from the blood, which means that we really need to be going counter current when we acquire our image. We want to go from bottom to top. And that means that we are going opposite of slice acquisition. And so every time we take a scan, every time we get a picture, it's bringing up a bright signal because we are going counter current to the flow in our slice acquisition. So ESP is going to give you different signal intensity within the stack of slices, just like we looked on page 208 and 209. As you move through the slice, depending on what you're doing with your flow and your acquisition of slices, is whether or not your signal is going to be bright or dark in the stack of slices. However, you hardly ever use it truly because you have flow compensation techniques like pre-saturation pulses, spatial pre-saturation pulses. When you use spatial pre-saturation pulses, you're pretty much eliminating that possibility of slices getting saturated out, or you're eliminating the possibility of slices being fresh. So you can kind of manipulate it in your own way. Okay, let's answer some real quick questions. First one, in entry slice phenomenon, nuclei that do not receive repeated RF pulses are called what? They produce a brighter signal than saturated signals. Go ahead, Reggie.
Fresh?
Yes. So whenever they're not getting the repeated RF pulses, they're called fresh spins or fresh blood. All right, next one. ESP magnitude is determined by the rate at which nuclei are what? Go ahead, Jasmine.
Excited?
Yes, the rate at which the nuclei are excited. That is correct. What are the 4 factors that affect ESP, Laura?
TR, slice thickness, velocity, and direction of flow.
Perfect. And which one, the last blank, which one is the most important factor and it's identified as blank or blank blank flow? Who can answer that one? Go ahead, Lena.
Direction of flow is the most important factor in ESP and is identified as either co-current or countercurrent.
Perfect. Co-current or counter-current flow. Awesome. Any questions about this before we move on to the third phenomenon? Okie dokie. Last phenomenon is called intravoxel dephasing. Oh, go ahead, Laura.
You said that this is not used in the clinical setting. Usually, where would it be used if we don't use it in the clinical setting?
Probably research. And the reason it's not really, it's not so much that it's not used in the clinical setting, it's that you can use flow compensation to make up for it, because entry slice phenomenon is something that you really don't want. You want to have a bright signal throughout the entire stack of slices so that you can actually visualize the blood and the vessel. So you really don't, think of these phenomenon as artifacts. We don't want artifacts typically, but sometimes we can use them to our advantage, like time of flight, which we'll see in just a little bit. But when it comes to entry slice phenomenon, the idea that we can lose signal from a slice as it's moving through is telling me that if I'm looking at vessels, I don't want entry slice phenomenon. When you look at page 208 and 209, these images of the axial abdomen were not done for the imaging of the vessels. These images were done for abdomen. We just happen to see that the vessels are showing up in different contrasts based on which direction, is it counter current or co-current, which direction of slices we're moving in. If we were actually looking at the vessels in the abdomen, we would be using flow compensation techniques so that we don't deal with this. And so if you are performing an angiography study and you notice that this is happening, then you know that you did not use a flow compensation technique like you needed to. So that's what it means by not seen in clinical imaging. Sometimes they'll use it in research, but I don't think that it's really something that could ever be helpful. It's not really a helpful thing to have this entry slice phenomenon because you're not getting the information that you need because you're saturating out the signal. So hopefully that answers the question. You don't want entry slice phenomenon to happen if you can prevent it. And that's what we do with our flow compensation techniques. Okay, so intravoxel dephasing is that third phenomenon that we encounter in flow imaging. And I try to condense these slides as much as I can, but sometimes it's hard because I can't tell you what the point is entirely without spelling it out for you. But pretty much what this is similar to when we were talking about aliasing and how we had spins from the outside of the volume of tissue that were kind of exhibiting the same phase as the spins inside of the volume of tissue. And so they were getting wrapped into the unit volume or the voxel, so to speak. So in intravoxel dephasing, when you have stationary nuclei and flowing nuclei in the same voxel, you're going to have them, they're going to end up being out of phase with each other because one is moving and one isn't. And so one is gaining phase and it's changing its phase position because it's consistently getting exposed to pulses, the stationary, while the other one is only getting it as it's coming through the slice. So you're always going to have spins that are out of phase with each other within the voxel. And what happens is it reduces the signal amplitude in the voxel. And that's what intravoxel dephasing is. Because remember, in order for us to get a really good signal from any unit volume of tissue, we have to make sure that our spins are all in the same phase direction. They're all in phase. But that's not going to happen when you have stationary nuclei next to flowing nuclei. They're never going to be in the same position. And that's a good thing for some purposes. For instance, when we want our spins, our flowing nuclei to show up really bright, we absolutely want our stationary to be dephased and dark. So it's not a bad thing, but it is a phenomenon that can happen. So the magnitude of the intravoxel dephasing is going to depend on the degree of turbulence, which is the flow of blood. So let's look at this image right here. You have a large voxel and a small voxel. Notice that in the small voxel, two spins are in the same phase, and two spins are kind of sort of in the same phase, but not quite. But they're almost close to each other to where you can kind of get a pretty decent signal from all four of them. In this box, you have them going in all sorts of directions. The larger the voxel, the more likely you're going to have dephasing within it because you have stationary and flowing nuclei. So in this particular anatomy, the stationary is the blood vessel and the flowing is the blood. And so you're going to have stationary nuclei showing up dark, and flowing nuclei showing up bright. So the ways that we can reduce it is by using a short time of echo. So that means that we're not going to allow dephasing to occur as much. And we're going to use smaller voxels so that we can kind of control how many spins we're going to be imaging at one time. And so it allows us to be able to collect signal that's more consistent with each other. Because remember, if this was a laminar flow, the outer edges are going to be low velocity. They're going to be not as fast as the middle, which is either fast or normal velocity. And so the outer edge spins are going to be in a completely different phase than the spins that are in the middle. And that's why the bigger your voxel, the more likely you're going to get that intravoxel dephasing, because you're collecting more spins that are possibly going to be completely out of phase with each other. So that's really all intravoxel dephasing is we run the risk of having, based on the direction of flow, based on the gradients we're applying, based on what kind of flow is happening in the vessel, whether it's laminar, vortex, turbulent, that's going to also determine if we're going to have as much dephasing. In turbulent flow, we cannot reverse intravoxel dephasing. There's nothing we can do to compensate for it. Turbulent flow is going to be flow that happens right outside of stenosis. It's also going to happen to patients who have some blood pressure issues, for instance, or if there's like tumors in the way. All sorts of different pathologies can cause turbulent flow. However, if it's happening in laminar flow, we can make up for it in gradient moment rephasing or gradient moment nulling compensation technique. And we'll talk about that today in just a little bit. Okay, any questions on any of the flow phenomenon that we just talked about? Please don't be afraid to ask questions, because somebody might be thinking the same question that you have. So it's not like a bad thing to ask a question. But the flow phenomenon that we just talked about is what is going to help us image our vasculature. And so it's really important to understand the types of flow, the flow phenomenon that we might encounter, what affects each of those phenomenon, so that we can then be able to compensate for them when we're imaging patients. And like everything else just about, this isn't something that you're going to be sitting in your job and trying to figure out on that tiny detail, you know, the really detailed information. It's really not, you as a technologist probably won't ever have to think about this unless you have to build protocols. This is all kind of built into the protocols that you're going to be using that we're about to talk about. But when you take the registry to be a registered technologist, which means you are knowledgeable, you have to understand this stuff on a more detailed basis. Okay, so let's talk about vascular imaging, which is the second part of today's lecture. Do you guys want to take a real quick break before we go into this? Let's take like a 5-minute break. I need a 5-minute break. So let's do 5 minutes and we will be right back. Okay, I'm back. Okay, hopefully everybody's back on. So we did the flow phenomenons and, you know, just how the flow in the vessels affects the signal intensity that we're getting from those spins, from the flowing nuclei. So blood, CSF, those are the two primary ones that we actually can image for flow. So now we're going to actually talk about vascular imaging. And this is in chapter 8, which starts on page 261. And we're only going to get through the chapter through page 290, because on page 290 is cardiac, and we actually go over cardiac next semester. So we're not going to focus on cardiac today. We're just going to be looking at vascular imaging. This is a lot of pages in this chapter, and I've condensed it down to just the very minimal information. I still need you guys to read these chapters because you do need to kind of understand all of the extra details. I just can't throw it all into this lecture because it would just take us an extra 3 hours. So make sure you're reading the chapters and allowing yourself to actually understand the material on a deeper level. Okay, so we are able to use MRI to look at the flow inside of the vessels as well as the vessels themselves. So the hemodynamic velocity, which is the flow within the vessel, and the morphologic display or the anatomy of the vessel. So that's what we are looking at. If you look at page 262 on figure 8.1, this is just two cross-sectional images of the heart. Really, it's the pulmonary arteries. There's, you can see the vasculature as it's coming out of the aorta into the pulmonary region. And so one image, which is the axial T1 spin echo, is visualizing the vasculature. The other image, which is an axial T1 gradient echo, is visualizing the blood. And this is kind of, in a nutshell, what the difference is between spin echo and gradient echo sequences, conventional versus the gradient echo. Conventional is going to be black blood imaging, and gradient echo is going to be bright blood imaging. So we're either going to be using our techniques to look at the vessel, or we're going to be using our techniques to look at the blood in the vessels. MRI is the conventional use of our modality, and that is going to allow us to look at the vasculature, the actual anatomy. MRA, angiography, we're looking at the moving blood. So both are going to be used for neurovascular, cardiovascular, and peripheral vascular systems. All of the different vasculature in all the different systems in our body. Both of these types of acquisitions depend on the motion of blood within the vessel. And the imaging of blood is usually going to primarily rely on first order motion. That first order motion is that laminar flow for optimum image quality. Now, we know that most of our patients are not optimal health. So therefore, we're not going to run into too many patients that have amazing first order motion of flow. But normally, in an ideal situation, we are going to be looking at first order motion as our optimal type of imaging that we're looking at, our optimal type of blood flow. So MRI, like I said, this is what is going to look at the vasculature, not the actual blood. We're looking at the structures of the blood vessels, the heart, the arteries, the veins, etc. We can use spin echo with spatial presaturation, and we call these black blood imaging techniques. Gradient echo with gradient moment nulling for bright blood imaging, or subtraction techniques. And subtraction techniques are going to be allowing us to have even better visualization of vascular structure. So we'll look at those each right now. And then MRA techniques are the ones that we're using to actually look at the blood. So digital subtraction, MRA, where we are injecting contrast and then subtracting one image from the other. Time of flight, notice that that's the same thing as the phenomenon we just talked about. So we're actually using that phenomenon to our advantage by creating contrast with it. Phase contrast, which has to do with getting contrast from the blood based on the phase position. And contrast enhanced MRA, which is multi-phase and Cine acquisition, similar to digital subtraction, but just different processes of acquiring it. So there's these 3 ways of acquiring images in MRI for vasculature, and then there's these 4 ways of acquiring images for MRA blood imaging. So let's look at the MRI techniques first. And again, this is a very detailed, this is why I gave you guys so much time to take the test, because you do need to go back and review this multiple times. Conventional MRI vascular imaging, conventional MRI. So we're talking about, we're using basic MRI techniques, not angiography. This is just MRI. When we were talking about pulse sequences, there was conventional spin echo and then there was gradient echo. This is more talking about, in general, we're just using regular MRI techniques, spin and gradient. So conventional MRI, not angiography, MRI can be used to evaluate the vasculature. We're looking at the structure of the vessels that we are imaging. So we can use spin echo, fast spin echo, inversion recovery, or gradient echo sequences to image the structure of the vasculature. That's a lot of different sequences that you can use. So you use whatever works for you and whatever you need from your image contrast. Notice that these 3 up here are termed black blood imaging. That's because all 3 of these are spin echo sequences. And in spin echo sequences, we are always going to have a signal void. This goes back to the time of flight part of the lecture, where spin echo creates a signal void. So when we're using spin echo sequences to create our images, we are always going to have black blood imaging, a signal void. Gradient echo sequences are going to create images where the signal is bright. Remember, this is because we are using gradients to rephase, so they're not slice selective. So every spin gets rephased, and the spins that have been excited will always produce a signal because they're always going to get rephased. So we call gradient echo sequences bright blood imaging. And so if you look at that figure 8.1 again, spin echo is black and gradient echo is bright. And so that's a really good kind of visual representation of the difference between them. So let's look at black blood imaging techniques. Remember, these are spin echo, fast spin echo, and inversion recovery techniques. So in black blood imaging with spin echo, we are going to be using pre-saturation pulses, sat bands or sat pulses. They're all kind of the same thing. Multiple different terms that mean the same exact thing. Sat band, sat pulse. Pre-saturation. Typically, when you want to saturate something out, it's always going to be pre. You hardly ever see yourself saturating something after it's been exposed to excitation pulse. You almost always want to saturate something ahead of time. So anytime you see saturation, sat band, sat pulse, it's always going to have the term pre behind it. You may not see it, but it's implied, okay? So with spin echo sequences, we're going to use sat bands to saturate out whatever we don't want to look at. And so we're going to be saturating out the tissue and whatever is outside of the imaging volume. And that means the flowing blood, because the flowing blood that's outside of that volume is just about to come into the vessel. So right before it comes into the vessel and we look at it, we want to saturate it out. This is why MRI techniques are for vascular visibility. We're looking at the structure, not the blood. So we want to saturate the blood out so that we can actually look at the structure itself, the vessel itself. So this reduces the signal from inflowing blood, especially when we use T1 weighting, because T1 weighting is already reducing the signal from fluid, which blood is a fluid. So we're using a SAT band and T1 weighting. So we're kind of double whammying it and making sure 1000% that we are not going to get a signal from the blood. So when we do this and we apply a SAT band, if we still see a signal of blood after we apply the SAT band, then it means that there's either slow flow, a blood clot, or vascular occlusion that is keeping some of that blood in the vessel when we expose it to excitation and rephasing. So after you've used a SAT band during spin echo sequences, if you see any type of signal from blood in the actual slice, that means that there is some issue going on. So a good example of this, even though we're not really talking, even though it's not a spin echo sequence, is for instance like with DWI and perfusion weighting. Even though those are gradient echo sequences, we know that if we see signal, that means that there is something happening. There's something wrong, because technically there shouldn't be a signal. So that's kind of what this means. When you use a SAT band, if you still see a blood signal, there is something wrong in that blood vessel. Okay, so how does that work? Well, just like I said, you're going to place the pre-saturation band or pulse right before the excitation pulse. So it's going to be an actual block or box that you will put over the anatomy right before the unit volume of tissue that you're looking at. So if this is the unit volume of tissue that I'm looking at right here, I want my SAT band to go right before it. Notice that here you have two different arrows. You've got the direction of flow in the vessel, and then you have V0 direction. So the direction of flow is telling you that the blood is flowing down this way from top to bottom. So if I'm looking at this portion of the vessel, then I don't want the signal from this blood to show up in this portion of the vessel because it's going to be moving into it. So therefore, I place my SAT band right in the area before the unit volume so that I'm saturating out any of that blood that comes through. A good example of this, for instance, is if you're doing an MRA, you're going to be putting your SAT band over the vessels that are venous, because your venous flow is opposite of your arterial flow, and it's going to come into the picture when you don't want it to. So you put the SAT band over your venous flow so that it does not show up in your arterial flow images. Hopefully that makes sense for you guys. And for those that are not in clinic right now, once you get into clinic, this will make more sense to you. So the SAT band is going to flip the magnetization of blood flow 90 degrees before it enters the imaging volume. And then when it's excited in the imaging volume, it's actually going to be exposed to another 90 degrees, and 90 plus 90 is 180, and 180 is an inversion pulse. So instead of us pushing you can use an inversion pulse, because remember, one of the sequences you can use is inversion recovery. So right now we're just talking about basic spin echo. When you do an inversion recovery black blood imaging, you're using an inversion pulse, which is really the same exact thing as a SAT band, just less steps. So with a SAT band, you notice that the longitudinal magnetization is pointing up. So initially, your spins are all pointing up. Now, this is not the direction of flow. This is the direction of their magnetic vectors, okay? So the blood can be flowing in one direction while its vector is pointing the other way, because the vector is related to the magnetic field and the flow is related to the movement of the blood. So initially, your spins are pointing up. They're moving down. The nuclei are moving down, but their magnetic spins are pointing up longitudinally with the magnetic field. We push a SAT pulse of 90 degrees. Well, 90 degrees pushes them into the transverse plane. Okay, so now your spins, as they're continuing to move down the vessel, are now pointing 90 degrees in the transverse plane. Once they enter the excitation field, which is the actual slice, and they get excited with another pulse of 90 degrees, they are now out of the transverse into the inverse and no longer producing a signal. So we have saturated them out using a SAT band. The other way you can do this, like I said, was an inversion pulse. So instead of using a sat band, we start with an inversion pulse of 180, automatically push them into the inverse plane, and now we've saturated them out. So you can do it one of two ways. Inversion pulse sequences take longer, especially in spin echo. The only inversion pulses that don't take as long are flare and stir, and those are gradient echo sequences. So when we're talking about black blood imaging, we're talking about spin echo. So inversion recovery in spin echo is very long, and you don't really want to use it when you're talking about flow imaging because you're trying to catch things. You're not trying to wait forever. So sat bands work better and they're faster because they're actually happening in the same time frame as your sequence. Sat bands do not add extra time to your pulse. Inversion pulses do. So sat pulses allow us to saturate out the signal from blood, producing black imaging or black blood imaging. So this is a couple of images that are black blood imaging. This is a short axis double inversion recovery of the heart. Remember, we have two different prep sequences for cardiac that we've talked about before, double and triple inversion, double IR and triple IR. Those are spin echo sequences. This is a double inversion, and so it has produced black blood imaging. And notice how the lumen of the aorta and the heart vessel and the ventricles is just like, it just looks perfect. It's so nice and defined. We can see the structure. We can see if there's any occlusions. You can see the borders. This is the lung, of course, but this is, I think, the ventricle and the atria, or no, this is the atria and the ventricle. Sorry, the atria is the smaller of the two. So this is the atria and this is the ventricle of the heart. Again, we'll talk about cardiac imaging next semester and you'll understand short axis when we do that. But notice how the blood is black. We don't see any blood in a vessel. Here is a great example of black blood imaging that looks amazing, where you can see all the vessels in the brain just beautifully. Just because we're not seeing the signal from the blood does not mean we're not getting diagnostic information. It's just depending on what you want to look at. Are you trying to look at the flow of blood? Or are you trying to look at the vasculature? Two different things, both very important. A lot of times you'll be doing both in one sequence. Okay, so that's black blood imaging. And like I said, we use spin echo, fast spin echo, inversion recovery, or gradient echo to produce vasculature imaging. Black blood imaging is going to be the conventional spin echo sequences, spin echo, fast spin echo, and inversion. Now let's look at bright blood imaging, which is using MRI technique, gradient echo. Remember, gradient echo sequences are always going to be bright blood because we're always going to get to rephase our excited pulses with the gradients. And because gradients are not slice selective, we will always be able to get a signal from flowing nuclei because they're always going to get rephased after excitation in the slice, in the actual slice we're looking at. Even though the rephasing is not slice selective, we are only picking up the signal from that particular slice because we've designated it in our slice select. But when we actually rephase with a gradient, it's rephasing everything and we get a signal no matter what. So nuclei are always in phase because they're always rephased, which means they always produce a bright signal. Now, when we use gradient echo for bright blood imaging, we can also use a technique called gradient moment nulling, which if you turn to page 268, this is an image, an axial gradient echo image of the chest acquired with gradient moment nulling. And so what gradient moment nulling does is it kind of rephases even more. So not only are we using the regular gradient to rephase our spins, but we're also correcting for any extra inhomogeneities, any extra out of phase spins using the gradient moment nulling technique. And remember, that's for first order motion, laminar flow. So it's not going to compensate for everything. This is why gradient echo sequences are not going to be perfect because you can't make up for all of the little issues that might come up with our spins. But what we're doing is we're going to rephase our moving spins with our stationary spins, and that's going to reduce intravoxel dephasing. So gradient moment nulling is really good for getting rid of that intravoxel dephasing that we might encounter. We talked about intravoxel dephasing and how we can use short TE and small voxels to make up for it, but you can also use gradient moment nulling if neither of these options are allowed. You know, you need a long time of echo, you need a bigger voxel, because remember, bigger voxels mean more spins. So maybe you need a bigger voxel, maybe you have a bigger voxel because you have a big field of view, or maybe you have a big voxel because you have a small matrix. So there's reasons why you couldn't use a small voxel. And so when you can't use a small voxel or a short time of echo, then if you use gradient moment nulling, I hope I don't like make you guys dizzy when I do this. Whenever you use gradient moment nulling, you're actually able to make up for that intravoxel dephasing in another way. So what it does is it makes the vessels with slow moving nuclei actually appear bright. And that allows us to look at those areas where there might be some slow flow happening. Make sure that you guys are reading that learning point on page 268. It's very small. Well, I'll just read it for you. It says pre-saturation can be used on both spin echo and gradient echo pulse sequences. And in some instances, it is appropriate to use both pre-saturation or sat bands and gradient moment nulling in the same sequence. Another technique to enhance the signal from flowing blood is the administration of contrast. So you can use everything in your toolbox to make your image as beautiful as possible and to make up all those little things that might come up, like dephasing, spins, intravoxel dephasing, etc. So you could use a sat band plus gradient moment nulling and have a really nice signal. So we use gradient moment nulling in brain, body, and extremity imaging. Really, you use all of these in all of the areas of the body. So if you look at these bright blood imaging, ignore this arrow right now. Notice that this is the heart. This is a axial view of the heart, and the patient does not have a very round body. That's not because the patient is deformed. It's actually because we have angled our acquisition box, our field of view, to the angle, the axial angle of the heart. So when you're doing heart imaging, the rest of the body is going to look really contorted, but the heart is going to look really pretty. So this is an axial view of the heart. It's kind of like an oblique view, actually. And notice how the blood is very bright in the heart. And this is that interventricular septum. Look at how nice and thick it is and dark because it's a structure. So we're actually looking at bright blood. So we're not looking at structure right now. This is also another bright blood imaging technique where you can see the cow and you can kind of see all the different structures within it. And it looks like this patient has some occlusion on both of these areas, unless it's just the slices, honey. So let's talk about gradient moment nulling just a little bit more. Remember, this is a compensation technique that we use to reduce intravoxel dephasing with flow imaging. It's most effective on that slow laminar flow. So the best time to use gradient moment nulling is when you're looking at venous flow, because it's slow and it's consistent velocity, consistent direction. That's about one of the only structures or vasculatures in your body that will have laminar flow. So anytime you hear laminar flow, just think venous, veins, inferior vena cava, you know, all the different venous flow that's in the body. That's what laminar flow is. So the gradient moment nulling technique is just like the balanced gradient system that we have talked about before. And if you don't remember this, go to Unit 1B, Chapter 5, page 175. Also, we talk about balanced gradient systems. All it is just an extra gradient that corrects the phase of the nuclei. And so by correcting the phase of the nuclei, we're not going to lose or gain phase. And so we're going to have a coherent signal from all the nuclei in that slice. And we can either use slice select or frequency encoding gradients as gradient moment nulling. It can be either one of those that we use to create that process. It's a double negative lobe, and it refocuses all the spins. By doing that, we can allow for much shorter time of echo. This phrase right here is confusing. Increases minimum TE. It's like a oxymoron. It's allowing us to have more latitude with how short our time of echo can be, because we're rephasing our pulse, our spins, to where we don't need any time to wait and pick up the signal. The signal's ready to go because we've already rephased everything and it's good to go. But because we're using extra gradients, it's going to decrease the amount of available slices for us, and we may have to increase our TR to add more slices. So notice how your compensation techniques now, you have to kind of figure out what's more important. More slices, short TE, gradient moment nulling. Those are all things that you'll learn as you get better at your job. It's not something that you're going to just learn from a book. So this image right here is just showing you that with no gradient, you have a stationary spin and a flowing spin in the same direction because they're both aligned to B naught. Gradient is applied positively at X1. X1 is your excitation pulse. So we apply a gradient and we flip it into the transverse plane. And so at this point, we've applied a pulse of 90 degrees. Even though it's a gradient echo, we've applied a 90-degree pulse. So now our spin is going to be in the 90-degree transverse plane. Then we apply another gradient negatively to flip it into the negative or the rewound 180. So now it goes from 90 to the 180. And then we apply a positive pulse gradient, I guess you could say, and it brings it back to 90. So what we're doing is we're pretty much resetting it. We're just using two negatives and a positive, two positives and a negative. And well, this is supposed to be two negatives. Just look at this right here, double negative lobe. Don't pay attention to what this picture is saying. We're applying two negative pulses and a positive pulse, and it's allowing us to reset our phase for moving nuclei. That's all gradient moment nulling is. Extra gradient lobes to reset our phases and bring them back into phase. So you can't really see too much difference between these, but what I can see is right here and right here without gradient moment nulling, you've got all this weird signal coming off of vessels that isn't accurate, because it's going out of phase, and so it's producing a different type of signal. So with gradient moment nulling, we kind of cleaned it up. It just looks a lot cleaner. There's not any signal in vessels that don't need to be there, and the signal in the vessels themselves is bright and clear. So gradient moment nulling is a subtle change from one image to the next, but instead of us thinking that there's something going on with the patient in this area, we're actually getting a really nice, clean, crisp image because we're putting all of our spins back into phase. All right, knowledge check. Conventional MRI blood imaging techniques are used to visualize what? Conventional. Go ahead, Reggie.
That would be the vascular.
Yep, the vasculature or the vascular structure. Exactly. Yep. Good job. Next one. Blank blood imaging creates images where blood signal is nullified. What is that called? Go ahead, Laura.
Black blood?
Yes. Black blood imaging is where the signal is nullified. We don't have a signal from the blood. What type of blood imaging uses gradient echo sequences and this type of compensation technique? Go ahead, Lena.
White blood imaging uses GRE sequences and gradient nulling moment compensation technique?
Yes, bright blood imaging uses GRE sequences and gradient moment nulling compensation techniques, GMN. Last one, blah, 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 uses the same technique as balanced gradient systems to correct what of the nuclei? This is the same thing as the one before, pretty much. Any guesses? Go ahead, Reggie.
I'm gonna guess.
Yeah, go ahead.
Gradient moment nulling uses the same technique as balanced gradient system to correct out of phase of the nuclei.
Just phase. It's going to correct the phase of nuclei.
Oh, okay.
That is correct. Good job. Gradient moment nulling. Gradient moment nulling uses the same technique as balanced gradient systems to correct the phase of nuclei. Or phases of nuclei.
Or phases.
Yeah, either one. All right, good job, y'all. So that was our MRI techniques. Remember, MRI is used for vasculature. We're looking at the structure of the vessels. MRA is looking at the blood in the vessels. So let's look at these. These are actually what you will be typically using more frequently than regular MRI. You'll use both, but MRA is what you're going to see more frequently ordered. So this is the more sophisticated way of looking at our vascular system. We're going to actually look at the flow of the blood in the vessels rather than the vessels themselves. We're going to see if there's any kind of occlusions, any kind of blockages or slow flowing blood, etc. So MRA uses variations of gradient echo acquisitions. In other words, MRA is always gradient echo. Okay, that's a very hard set rule. If you're using MRI to view vessels and vasculature and angiography, you're actually looking at the vessels, which are stationary, just like your liver, just like your, lungs, for instance. So MRI is looking at stationary structures. MRA is actually looking at the flowing nuclei within those structures. So we maximize our contrast by enhancing the signal from the flowing spins or suppressing the signal from the stationary spins. And you can do both at the same time too. So when you suppress the stationary spins, you're increasing your entry slice phenomenon, which is brighter in flow. So it just depends on what you're looking for. Remember, I said you don't always want the entry slice phenomenon. You kind of want to make sure that you see your signal always throughout the entire structure. You don't want to miss the flowing nuclei signal. So even though it's increasing that entry slice phenomenon, you've got to come up with a way to make up for that. The best way to make up for it is to make sure that you are going counter current. Because if you go counter current, where you're acquiring your slices opposite the direction of blood flow, you're going to have brighter signal in the vessels longer, because your blood is going to be fresh longer because it hasn't been excited over and over and over again. So the 4 types of MRA techniques that we use are digital subtraction, MRA, and I've just provided the abbreviations because these are really what you'll see on the consoles and also on your registry. This might be what they say, DSMRA, rather than digital subtraction. So just be familiar with the abbreviations. Digital subtraction MRA, time of flight MRA, phase contrast MRA, and contrast enhanced MRA. So we're going to talk about each of these right now. Digital subtraction MRA is fresh blood imaging. That's what we call it. It allows us to look at vasculature in a bigger field of view. So for instance, we could use digital subtraction for carotids, for the abdominal aorta. We could even use digital subtraction in our, I can't ever think of the word. And Laura always has the right word because she does it at her job. What is it called? Why can't I think of this right now? Runoffs, cheese and rice. So runoffs are where we're looking at the vasculature in the lower part of the body and we're watching it as it's moving through the entire vessels. And so we would use a large field of view for it. So digital subtraction MRA is really good for those bigger areas that we're looking at. What we pretty much do is we collect 2 T2 weighted data sets. Notice that we're doing T2 weighting for this bright blood imaging. When we were talking about conventional MRI, we were using T1 weighting because T1 weighting eliminates the fluid signal, and that's what we were trying to do. Now we're actually wanting to see the fluid signal, so we're gonna do whatever we can to make that happen. We're gonna use gradient echo, we're gonna use T2 weighting, we're gonna inject contrast, etc. So we're gonna use 2 T2 weighted images. One is gonna be acquired during systole, and one is going to be acquired during diastole. And we're going to subtract one from the other so that we can get that nice demonstration of the arteries and the veins. We're going to isolate the two from each other, and we're going to be able to see them separately. The contrast is reliant on motion, so it's not really a great depiction of anatomy. So notice that we're not looking at the vasculature, and we're not depending on it for vasculature. We're only looking at the flowing blood. Fresh blood imaging. And so if you have a patient that cannot have gadolinium and you've got the time and you're able to run this type of sequence, digital subtraction MRA is a great way to get blood imaging without contrast injection. A lot of times contrast is ordered for vasculature, or rather for blood imaging, because it guarantees a signal no matter what, just unless you screw it up yourself. Unless you screw up the timing of acquiring it after you inject. But using contrast is kind of a surefire way that we're going to get a signal no matter what. And so a lot of times doctors order it because it's guaranteed that they're going to see what's going on, rather than depending on the technologist to know what they're doing. They just have no faith in us. You know, that's all it is. So anyways, we're doing 2 T-weighted images, one during systole and one during diastole. Now, systole is going to exhibit signal loss due to intravoxel dephasing, and diastole is going to exhibit high signal because the flow is slower. You don't really have to remember this, but it's just kind of explaining it to you. But just remember that with digital subtraction, you're using the cycles of the cardiac cycle to actually create your image. Here's the systolic phase, and here is the diastolic phase. Remember, this is like the lub-dub, and then you wait. And then you hear another lub-dub, and then you wait. So we're pretty much taking our images as the blood is flowing based on that pulsatile cardiac cycle. And then we're getting those images, the slow flow in the veins and the fast flow in the arteries, and then we're going to subtract them from each other and create a really nice clear image. You can use this one when you, yes, Jasmine asked if we use this when patients can't have gadolinium only. It's not the only reason, but it is one of the reasons that you can use it. Sometimes it's just built into a full study for carotids, for instance. So you might have a subtraction carotid plus a contrast, or you might do one or the other. A lot of times it's based on what your reading radiologist prefers, as well as what your equipment can handle. There's a lot of different factors. That's why I'm saying this is not, you're not actually making the decision as a radiologist on which one you're using all the time. Typically, it's already built into your study that you're choosing, carotid study. It's going to have one sequence that's a subtraction sequence, plus a time of flight, plus a contrast. It just depends on what you're doing. But yes, you can use this whenever you cannot give patients contrast. It's a really good, quick way to get the images. So that's digital subtraction MRA. And I don't think there's any images in the book that I found. And any images that I found online were kind of not that great, but I wouldn't worry about that too much. You'll be able to tell subtraction images because one is going to be more grainy than the other. And subtraction images, the system itself does the subtraction for you. You're not doing, you might have to like click a couple of options to start the process, but you are not personally creating the subtraction, the images. The system will subtract it for you. Okay, time of flight MRA is the second type of bright blood imaging that we can use. We also call it inflow because remember, time of flight is about how fast the flowing nuclei is moving through the vessels. So it relies on flow-related enhancement. Remember, flow-related enhancement in time of flight, and I'm going to do a real quick scroll, so mind your eyeballs. So flow-related enhancement increases as the velocity of flow decreases, which is not something you can do anything about. The time of echo decreases and the slice thickness increases. So if the flow of blood is slow, if your time of echo is short, if your slice thickness is thicker, then you're going to have more flow-related enhancement, which means you're going to have a brighter signal. Okay, so we use incoherent or spoiled gradient echo with gradient moment nulling compensation technique. And so that compensation technique is going to prevent the phase ghosting mismapping because it's going to kind of put everything back in phase. So pretty much what we're doing is manipulating the longitudinal magnetization of the stationary spins to saturate them out. And then we're going to use the inflow effect or the time of flight effect so that we have these fresh spins that produce a high signal. That's another way of saying what that little chart says on the slide. We're just going to enhance the signal from the flowing blood as we reduce the signal from the stationary spins. We use time of flight in two different ways, 2D sequential or 3D volume acquisition. So let's look at what each of those means. 2D time of flight MRA is used for areas that have slower velocity flow and large field of view. So the carotids, the peripheral vascular and venous systems are going to have more of the slower velocity flow. So these are carotid arteries that they have used time of flight MRA to produce. This is not a contrast injection. We have used the flow phenomenon to our advantage and created contrast from what would typically be considered an artifact. So that's what's really cool about angiography studies. We are using artifacts to our advantage. So 2D is good for bigger areas and slow flow. Very important to remember what 2D versus 3D is used for. We're going to suppress the stationary while we maximize the signal of flowing nuclei. Now, I did put a little disclaimer here that says because of motion artifacts like breathing and swallowing in the carotid area, it's better to use contrast-enhanced MRA for carotids, which is why you hardly ever see time-of-flight carotids. Time of flight takes a long time to produce, depending on your magnet, because it depends solely on the flow of blood. So you are pretty much at the mercy of the patient's anatomy and physiology. And this, Jasmine, is another thing you can do if the patient can't have contrast, is time of flight, 2D or 3D. Time of flight, phase contrast, and why can't I think right now? Digital subtraction. Digital subtraction, time of flight, these three right here are used in various reasons, but one reason you can use these three is if your patient cannot have contrast. Because what you're doing is you're creating contrast from the anatomy and physiology of the patient. You're using those flight phenomenon to create contrast that isn't visible with other techniques. These are the MRA techniques that we use to create our bright blood imaging. So 2D MRA is good for slow flow and a large field of view, wide areas of coverage. 3D MRA is used for small vessels and high velocity blood flow. So it's the opposite. You're going to use it for things like the circle of Willis. So note this is a MIPPing where we've gotten the circle of Willis images and now we put it on the tumble setting. So after we MIP it and take all the extras out, and they could have done a better job of MIPPing here, I would have gotten all this gray stuff out of the way. Because the doctor prefers it when you cut out all the extra gray stuff. You just have to know what you're cutting out, because if you don't cut it out correctly, you're going to cut off some of the anatomy that they're looking at. But once we have created this circle of Willis image, we can flip it, spin it, tumble it, whatever. So we use 3D time of flight on this image because it's a high velocity blood flow. The brain has a high velocity blood flow, and it's smaller vessels, so we're using a smaller field of view. And if you go to, let me see, I guess figure 8.9, it's kind of showing you the smaller structure, and then underneath it, figure 8.10 is a 3D time of flight MRA to evaluate the structures of the circle of Willis. And notice how on page 273 on figure 8.10, the 3 Tesla versus the 1.5 Tesla, look at how much more detail you get in your image when you're using a much stronger magnet. You're getting a better image, you're getting more information, which sometimes the radiologists don't like because they have to read more information. Anything that's on the image, they're legally obligated to mention. So when there's more information on their image, there's more stuff that they have to read, but they don't get paid extra for it, so they get mad because they don't like 3T. Honestly, I feel like 3T is beautiful images, but almost to a point, too much information. Now, if you're in a research facility or if you deal with a lot of cancer patients, etc., absolutely the better magnet is 3 Tesla. But you really don't need a 3 Tesla, the images that you need. Because if you look at the 1.5 Tesla image, you're still getting the major structures. You're still getting the entire circle of Willis structure. So it's not necessarily that you're not getting enough information. So you're going to get a high signal to noise ratio because you're using that small field of view. And you're getting high resolution as well because you're able to, it's a 3D volume acquisition. So you're getting a chunk acquisition, and then the system is slicing it after the fact. So you don't miss any resolution. You're able to get the best of both worlds, the high signal to noise ratio and the high resolution. That's why 3D is really great for these small vascular structures, because we get the best of both worlds. So the trade-offs for 3D is that it's not good for slow venous flow. The spins take longer to flow through the 3D slab. So it might actually saturate those spins out and reduce their signal because they're moving really slowly. So you don't really use 3D time of flight for MRV, for instance, because venous flow is that laminar slow flow, and you'll lose your signal. And also it limits how thick your slab is. Again, because the bigger your slab, the more likely you're going to saturate out your signal, because your flowing blood is going to have multiple RF pulses that it's exposed to before it leaves the slab. So you're limited to how big the slab is, but for the most part, in smaller structures, 3D is great. Now, if you go to page 274 and 275, there's these 2 charts that give you the advantages and disadvantages of time of flight, 2D and 3D. And just in general, MRA advantages and disadvantages, and then 2D, 3D advantages and disadvantages. Look at them and read them. You're not going to get tested on these too much, for me at least. But it's good to know the difference and the advantages and disadvantages for when you start working, because you're going to have to be the one to make that call. Why radiologists don't like to read these, like the TCD. What are TCDS or TCDs? I don't know what that is.
Oh, that's ultrasound.
Oh, okay. Are you asking why they don't like to read it, or are you saying that's why they don't like to read it?
Well, there's a lot of them that don't read them, and
yeah,
they tend to just pass them off for a long period of time.
Are they more detailed?
It's just more detail. The TCDs are more signal-based than
gotcha.
structure-based.
Gotcha.
Yeah.
Okay. I don't know anything about ultrasound, so whatever you tell me, you're teaching me, because I have no clue. It looks like white noise on my TV.
this looks so much better. I mean, I'd rather read these because you actually see them.
Exactly.
And it just, I think it's just the new ones, the new radiologists that are coming out of school are just having a hard time reading these and reading the circle of Willis period.
Yeah, I believe you on that one. I always liked working with our older or
Yes,
longer tenured radiologists.
I
You
agree.
know, like I don't know if you guys know, like Dr. Jensen, Dr. Gloina. Those were like my favorite radiologists to work with because not only are they so informed, they have so much experience behind their back that they can pretty much teach you everything you need to know. They're awesome. But yeah, the younger doctors, they're kind of pushing them out faster, and I think also because of new technology, they're depending on the fact that the technology that's older, they're not going to have to use it anymore, and so
Right.
they don't care to even like spend the time to learn it, which is like detrimental, but whatever.
We can't argue.
Yeah, exactly. Okay, so 2D MRA, time of flight is good for slow velocity, large field of view. 3D is good for high velocity, small vessels, small field of view. All right, so we talked about digital subtraction MRA, time of flight MRA, and now we're going to talk about phase contrast MRA. Phase contrast MRA is literally what it says. We are creating contrast from the phase of the spins. Okay, so the signal is coming from the phase shift of the flowing nuclei. And the phase shift is velocity induced. And it occurs because you change the velocity or direction of the flow, or you apply additional gradients. So we were talking about gradient echo and using gradient moment nulling as a compensation technique. With phase contrast, we're not using gradient moment nulling. We're actually gradient moment nulling and VENCs, or velocity encoding gradients, are literally opposite of each other. So gradient moment nulling is bringing all the phases together and enhancing the signal of all the spins and the stationary nuclei all at once. VENCs are going to create a bigger phase shift in the flowing nuclei. So we're actually going to make them not have the same phase. We're going to make their phase shifts completely different. So the flowing nuclei are going to have a higher signal than the stationary nuclei. That's the gist of phase contrast MRA. We're going to use GRE with a small flip angle, and we're going to use what's called a bipolar VENC velocity encoding gradient. It's going to create a bigger shift difference between the stationary and the flowing nuclei. Remember, the phase shift is their position on the clock, on the face of the clock. When you have in-phase nuclei, all of them are going to be facing the same position. For instance, they're all going to be pointing to 3 o'clock. When you have a phase shift, you're going to have some that are pointing to 9 o'clock and some that are pointing to 3 o'clock. And then you're only going to collect the signal from the ones pointing to 3 o'clock. And then you collect other signal from the ones pointing to 9 o'clock. And then you digitally subtract them from each other to create your final image. So you're going to create this big phase shift between the two, pick up signal images from one data set for the 9 o'clock phase, one data set from the 3 o'clock phase, and then you're going to subtract them from each other to create the final image. If you go to page 280, it gives you like a nice little diagram of this bipolar velocity encoding gradient. So what I want you to look at, the top of the diagram is the encoding gradient, the VENC. Notice that the first lobe is positive and the second lobe is negative. So it's bipolar, positive and negative lobes. On the very beginning, you have your stationary spin and your flowing spin pointing in the same direction. Their phase is in the same direction, pointing to 12 o'clock. You apply your first lobe of the velocity encoding gradient. That is going to push them both into the transverse plane. Now, as the flowing spin is moving, it is losing its phase, just like the stationary spin is losing its phase as it stays stationary. Then you apply your second lobe, and now you have the stationary is going to have the lower end of that second lobe, and the moving is going to have the higher end. Notice that on the first lobe, it says higher, lower. On the second lobe, it says lower, higher. So higher and lower is the shift, the amount of shift that that gradient is creating. And it's based on its position on the gradient axis. So when the spin is on the second lobe, the moving spin is in the second lobe, it is actually receiving the higher end of the gradient. So its phase is shifting more than the stationary spin that is receiving the lower end of the gradient. So initially they're put in phase together, but the second lobe of the velocity encoding gradient is going to actually separate them from each other and give them two separate phase positions, so that when we pick up the signal from both of them, they're in different positions, and then we can subtract them from each other. So if you, and I actually included these, this image that's in your book on your slide as well. I just broke it up. So as you can see here, you kind of, it's really based on, first of all, the VENC gradient is something that we set. It's an external parameter, user definable parameter that we set before acquisition. Again, this is not something that you are going to have to do every single time you use this. It's just already set in the system by the physicist or the technologist or the radiologist that created your sequences. But it is something that you are setting, collective you, and it is the amplitude of the gradient. Remember when we talked about the amplitude of the gradient? When we set it to a certain speed of flow is when it's going to be applied. So for instance, if we have high velocity flow, we know that the arterial blood flow is high velocity, we're going to set it to a high VENC. It's measured in centimeters per second. So high VENC for the high velocity flow and low VENC for the low velocity flow. What we're trying to do is we're trying to catch the spins based on how fast they're moving so that we can then apply the gradient to them, okay? If they're moving slow, we've got to apply the gradient in a shorter amount of time. And if they're fast moving, we're going to apply it in a faster amount of time. So 10 centimeters per second versus 40 centimeters per second. And notice how the signal intensity is different in the structures depending on which VENC gradient you're using. You don't have to worry about going into too much detail with this. The only thing that I need you to really understand is, first of all, VENC is used in phase contrast MRA so that we create a phase shift of the flowing nuclei. That way we can collect multiple data sets at different phases and then digitally subtract them. We create the phase shift by applying a bipolar velocity encoding gradient. The bipolar velocity encoding gradient is going to allow us to create that phase shift that then produces different contrasts based on which flow we're looking at, the slow flow or the fast flow. And a high VNC is for high velocity or fast flow, and a low VENC is for low velocity or venous flow. Any questions on this? Always associate VENC with phase contrast MRA. They go hand in hand. Phase contrast MRA is another technique that you can use along with digital subtract MRA and time of flight MRA when you don't want to use contrast injection. Many reasons. The patient's allergic. You don't have any contrast because you ran out and you didn't order it on time. That's happened to me before. Yeah, you can laugh. It's okay. I cried a little bit and then I laughed. Also, if you are running their GFR and it's kind of low and the doctor's like, let's not worry about contrast. Let's just do a phase contrast. Phase contrast can take some time. Time of flight can take some time because it's based on the patient's anatomy and physiology. There is nothing you can do about it. It's similar to respiratory gating. When we are taking images based on the patient's inhalation and exhalation, there's nothing we can do about how fast or slow they breathe. We just got to wait for it to happen. Same thing with these flow-based contrast images. So let's look at the last type, which is, I'll just go over this real quick. Just like time of flight, phase contrast has 2D and 3D. And this is that bipolar gradient that we're talking about. And notice how down here, the blue line is the stationary spins phase. The orange line is the moving or flowing spins phase. When you apply the bipolar gradient, you're shifting them so far away from each other that now you're able to see a big difference between the two, so that when you subtract them from each other, there's a really nice different contrast. So the biggest difference between 2D and 3D is that 2D phase contrast cannot be reformatted in other imaging planes, and it's lower resolution. It also is going to provide us information on the direction of the flow, the velocity of the flow, and the multi-directional flow that it's occurring in the vessel. 3D phase contrast is going to give us much better signal-to-noise ratio and spatial resolution. Again, that's because we're using that 3D volume acquisition. So with 3D volume acquisition, you're able to get really good signal-to-noise ratio and high resolution, because you're not cutting it up into slices until after you've acquired it. So there's no worries about which part of K-space you're filling. You're just getting it all at one time. 3D, just like time of flight, 3D is used for smaller vessels. And you do need velocity, flow, and direction information. And so this is something that you would have to actually input into the system. A lot of times it's going to be like their pulse rate, for instance. You would have to take their pulse and then input that into the system, and also indicate which direction of flow you're looking at. If you're looking at carotids, for instance, you've got to say the direction of flow is bottom to top. If you're looking at arterial, if you're looking at venous, you've got to say my direction of flow is top to bottom. So those are things that you have to kind of select on the console. But 3D can be reformatted, just like 3D MRA time of flight is reformatted here. You can also reformat 3D phase contrast MRA in the same. It's going to look just like the time of flight images, and you can run a 3D phase contrast MRA circle of Willis, just like you can run a 3D phase contrast time of flight circle of Willis. You can use these for any structure. It just depends on what you're looking for and what you need. And again, it's not something that you yourself are deciding. Typically, it's been decided for you based on the sequences that have been inputted into the console. But you just need to know why they're there so that you can be called a technologist. Okay, so here's some images, 2D versus 3D. Notice that we're looking at the venous structure on 2D, and we're looking at the arterial structures on 3D, or rather the blood, not the structures, because this is bright blood imaging. So 2D phase contrast MRV, look how beautiful it is. And then 3D phase contrast MRA, and this is the kidneys right here. So we're looking at the what are they called? What are the kidney arteries called? Not the nephrogenic arteries. I can't think of them right now. But this is your abdominal aorta, and it's kind of bifurcating and breaking out into different areas. So anyways, these are the differences between the two. Phase contrast MRA, phase contrast MRV, looking at the blood flow, using the phase shift of the blood, the flowing nuclei, and the stationary nuclei. Okay, last one we're going to talk about today. Renal, thank you. Oh my gosh, why did I forget? You know, it's like, you know, you have the knowledge in your brain, but your brain is like, no, it's just not happening today. I swear I'm not this airheaded all the time. It's just Saturday mornings kind of kill me. Okay, contrast enhanced MRA. It's the standard that we use to evaluate the vessels of the body. The standard. The reason it's standard is because we will almost never miss what we're looking for, and it's much shorter. Time of flight, digital subtraction, and phase contrast MRA take forever. If your magnet is really old, you're going to be there for like an hour and a half. I used to work at Envision South Arlington, where Laura works, and we used to have this old Hitachi that was a dinosaur. We called it the dinosaur because it was a dinosaur. I had to run a phase contrast MRA on a patient, and I am not playing when I tell you it took me 2.5 hours to run a study on this patient, because their flow was so slow, and they were just, you know, claustrophobic and all sorts of, and the images were awful. And so anyways, phase contrast, time of flight, and digital subtraction MRA, they're great, but they can be time consuming. And so we will use contrast enhanced if the patient's body allows us to, because they're able to have contrast. This is a much better way to create those contrast images of the vessels and the blood in the vessels. So we use a T1 3D gradient echo, and then we follow it. Notice that we're using T1, okay? So we're going to eliminate all the fluid signal in the body, and then we're going to inject gadolinium, and we're going to take dynamic images. So you don't always have to use, like for instance, with the Circle of Willis, you don't need to inject contrast, and you don't need dynamic images. You really can just run a time of flight and be fine. But when you're looking at the liver, for instance, and looking at the hepatic arteries and veins of the liver, then you want to use dynamic images to watch the blood flow through the different areas. Always want to use a bolus injection with a power injector. That's the standard. You can use a hand injection, but a bolus injection is more accurate. It's consistent across the board. No matter who performs the exam, you're going to always have the same exact rate of injection. And if you're working by yourself, it allows you to actually perform the exam on your own, which ideally you want to be a two-person team in MRI, but some places don't have that. I know it's becoming more standard now because of ACR accreditation. They require you to have 2 MRI techs at one time, always. But some places are not ACR accredited, so you may not have 2 people working together. In that case, using contrast and MRA is helpful because you can use your bolus injector, and therefore you're able to perform the study on your own. So again, you can use hand injection, but bolus and power injector is usually better. So what you do is you take images before, images during, and images after the injection. That's that dynamic imaging. The before is like your scout. During and after is the dynamic images. You take images as the injection is going in, you take images throughout the injection moving through the vessels, and then you take images after all of the contrast has been pushed through the patient. Or you can time them for arterial, intermediate, and venous phases of the vascular cycle. So it just depends on what you're familiar with, what the settings of the system are, how the location does it, how the radiologist wants it, etc. But with contrast enhanced MRA, you are going to be using gadolinium to create the contrast rather than the flow of the blood. So if you go to page 287 on figure 8.20, and in the book there's also pictures that I have not referenced that you should definitely look at for the other sections that we talked about. I just, you know, like I said, if I was referencing everything in the book, I might as well just read the book to you. Okay, so figure 8.20 on page 287, these are coronal contrast enhanced MRA, CEMRA. Remember your acronyms of the abdomen acquired before, which is the top image, after, which and after images are the 2 bottom ones. The image on the bottom left, your left, is arterial phase, and the image on the bottom right is after that, the intermediate and the corticovenous phase. So notice how they've done before, during, and after. Before, during injection, and as the contrast is moving through the phases. So that's kind of what you would be doing. These pictures are really pretty. You may not always have pictures this pretty because your patients are not always going to be this lovely. And so whenever it says down here on the same page, it says technical considerations for enhanced MRA. Enhanced is contrast enhanced. Sometimes you hear enhanced, sometimes you hear contrast enhanced. Same thing. Enhanced means that we've enhanced it with something external like contrast. So protocol parameters, injection method, contrast type and dosage, and scan timing. These are all things that as you get better, you're going to kind of already know. You know, this patient needs this much contrast dosing. I know I need to be able to inject it at this rate, but their blood vessels are awful and I need to go slower. So that means I need to slow my time. All of these things are things that you will kind of get more better at as you continue to use contrast enhanced MRA. If you have time to read that green box on page 287, that says parameters and options for CE-MRA. I recommend you read it. I don't necessarily expect you to memorize all of it, but definitely read it. If you turn to page 289 on figure 8.21, look at the subtracted versus non-subtracted MIP images. The non-subtracted just has a lot of soft tissue that we really don't need. So the system has subtracted the contrast enhanced the MIP from the non-subtracted. It's kind of taken it away from itself. It isolates the vessels and makes them look really pretty. Okay, let's do this knowledge check, and then we just have a real quick couple of slides. The 4 types of MRA techniques are what? Go ahead, Reggie.
The digital subtraction, the time of flight, the phase contrast, and the contrast enhanced.
Perfect. And just make sure that when you guys are studying these that you're actually remembering the acronyms as well. Next blank. Something is also known as fresh blood imaging, MRA. Which one of the 4 is fresh blood? Go ahead, Laura.
Digital subtraction.
Perfect. Digital subtraction MRA is fresh blood imaging. All right. The next one, blank and blank can be acquired in 2 ways. Blank and blank. So 2 different types of MRAs can be acquired in 2 different ways. What are those ways? Go ahead, Laura.
Now, I took a guess on this one. I'm not 100% sure, but I think it's time of flight and phase contrast can be acquired in 2 ways, 2D and 3D.
Yep. So time of flight MRA and phase contrast MRA can both be acquired in 2D and 3D. Make sure that you understand what each of those means for time of flight and for phase contrast. All right. And what is usually done with a bolus injection of contrast for speed and accuracy? Which of the techniques? Jasmine?
Contrast enhanced MRA.
Perfect. Anytime you hear bolus injection of contrast, it's contrast enhanced or just enhanced MRA. Good job. All right. When we talk about MIPing and flipping and spinning and tumbling, we're talking about reformatting the images. So I'm just going to kind of real briefly go over this. Maximum intensity projection, or MIP, and we kind of I mentioned this briefly in your last unit. Make sure that you're reading page 76 for MIPing. Is it page 76? Why did I have page 76 on here? I wasn't in this section before. That's not right. It's actually, I think it's 276 is what I was trying to say. Yeah, it's page 276. Figures 811, 812, and 813. Read through these. It's a lot of information. When you're actually working on this stuff in clinic, you're not going to be really focused on these details, but just make sure that you're reading through the page 276 on reformatting, MRA image reformatting, and then look at the images that are associated with it. So what we do with MIPing is we reformat images to make them look like they're on a 2D surface. So there's no depth cueing, really. It's hard to tell which vessels are in front of other vessels and which are behind. And the way that MIPing happens is there's numerical values that we assign to the pixel, to each pixel on a grayscale. So it's kind of similar to when we're doing data acquisition and case-based. We're giving a grayscale to each pixel based on a numerical value, and that's on figure 812. Entire stack of images can then be rotated around an axis which the technologist chooses. So if you go to figure 813, notice that they are looking at the aorta is what it looks like, and they have MIPed it, and now they're flipping it and spinning it around. And that very top left-hand corner image, the bigger of all of the images, it has that line across the middle with the little lines that look like sunbursts. That is the axis that you are going to be flipping and rotating around. So you just go in there and you just kind of decide which direction you want it to flip and rotate. And then the radiologist can scroll with their mouse and be able to actually see the image flipping and rotating, similar to this picture right here, and how it's kind of tumbling on itself. So that's what MIPing is. This is a MIP right here. And then the other one that we talk about, and it says you can repeat this many times to create various angles of viewing, which is similar to like CT. If you guys do CT, you're able to recreate the same structure in different planes and in different angles so that they can see it from all the way around. In SSD, or shaded surface display, this is 3D imaging. It's going to actually give you edge detection. It's going to allow structures to appear either in front of or behind other structures. It's much more 3D based. And so it gives you that optical illusion using pixels and algorithms. So it's not something that you actually do yourself. The system does it for you. So this is what MIPPing looks like. This is the renal artery off of the main abdominal aorta, the right renal and the left renal. And so they've done some MIPPing to this, not very much because I would have cut out all this gray stuff right here. This is the circle of Willis that they have MIPPed perfectly. This is beautiful MIPPing because look, all you see is just the structure. There's no gray around it. This is what radiologists prefer, but you have to know what you're cutting out. You don't want to cut stuff that you need. So you will get better at this over time as you get more comfortable with the anatomy. This is the difference between MIPPing and SSD. Remember, SSD gives you that depth perception, so you're able to actually see the structures, what's in front, what's behind. It looks like you're actually looking at a cross-section of the brain, of somebody's brain, rather than an image on a screen, where this is MIPPing and you can't tell what's in front and what's behind. If you look at this area of the circle of Willis versus right here, I mean, it's night and day difference. You can see the edges better, the shading. That's why it's called shaded surface display, because that algorithm gives you that optical illusion of shading right here that makes it look like a 3D structure. So that's really it. That's the gist of what I wanted to talk about today.